I'm a consultant at IHA and support the MB-QUIP program. And Ali Orwig with the Indiana Rural Health Association is hosting our Zoom platform today. And want to thank Ali for all of her support and making sure that the Zoom meetings all run very smoothly. We're continuing our discussion today with Amber Boatright, who's a clinical specialist, physical therapist, director of rehab, works multiple jobs and positions, but she has been a great resource for us in providing some of the out-of-the-box thinking around physical therapy and swing bed programs. So today's session is a continuation of a discussion from our February session, because we now are meeting every other month for swing bed education. Because there were several questions as Amber presented, and we simply ran out of time, and definitely she had more important information to cover. Carrie Dunning is also on the line. Carrie is our national consultant for swing bed, who's done both work here in the United States and a lot of post-acute care work internationally, and is just a wealth of knowledge to help us build and support the swing bed programs here in Indiana. So want to shout out to Carrie too. But Amber, I will go ahead. I will turn it over to you so that we can begin today's discussion. I do encourage everyone to open up the chat function by hovering either at the bottom or the top of your screen, depending on the computer you have, clicking on chat and using that chat function for questions. Likewise, you are welcome to unmute yourself and ask questions directly, again, by hovering either at the top or the bottom of your screen and unmuting yourself by clicking on the microphone icon. Also, open up the participant list. See who else is on the call. You may want to have a conversation with others that are have joined. Been difficult to network with others at other hospitals the last few years because of COVID. And so definitely feel free to interact with each other individually. But you can also unmute your line next to your name. There's a microphone button there as well. It will show up red right now with a line across it because we have muted everyone upon entry to cut down on any type of background noise. Likewise, if you would like to put your name and the hospital that you're associated with, we have a lot of physical therapists on today, and I'm not necessarily familiar with those names, but would like to know what hospitals are being represented on the call so we can take an accurate attendance. And so if you could put your name and hospital in chat, that's very helpful to us as well. So Amber, take it away.
Okay. I think I am unmuted. I am. Okay. So like Becky said, my name is Amber Boatright. I am a physical therapist, clinical specialist, and director of rehab for a rural hospital right now in Southeast Georgia. And for those of you that were on last time, I thank you for coming back and joining us again. You got a little bit of my bio then, and you also did not get my true voice last time. I was sick. I was just telling Becky we're again now having all 4 seasons in one day. We wake up, it's 45, by lunch it's 86. So I have somehow missed some sort of cold this time, but I am still country, but I'm not sick this time. So I am glad to be back with you guys. Just a little bit about me. If you weren't here last time, I did graduate from the Armstrong Atlantic State University with my bachelor's, and then I went on to Medical College of Georgia in consortium with Armstrong Atlantic State University. In 2009, I earned my doctorate degree. I am a certified fall prevention specialist, and I have used these skills in a variety of settings. Currently, I work in a hospital who has acute hospital, swing beds, skilled nursing facility, psychiatric ward, and outpatient clinics. I've been with Vencura, which is a rehabilitation management company that I love. I've been with them for 12 years. I've taken on multiple roles with them. I started out as a staff therapist, went to director of rehab, moved up to clinical specialist, and now I'm also serving as director of rehab again in one of our local hospitals. So that's kind of just a little bit about me. I am married with 3 children, 4 goats, 8 chickens, a dog, and a cat. So we're busy with life on the farm. All right. So I do want to say there are 2 questions that were brought to me this morning from Becky. I think they were emailed to her. And so what I'm going to do is just wait until the end and address those 2 questions. And then if there are any more, then I would be glad to answer those as well. But I'm going to rewind here for just a moment. I think we ended our last session. I had to kind of vomit out the last part of my presentation after standardized tests last session because of the time constraints. But standardized testing, it was asked of me to provide some of my favorites. And these are some of the ones that I use most of the time. It does depend on what setting I'm in, which looking over these, I can use these in any setting, actually. It just depends on like Berg. I'm just not going to do that for a low level sniff patient. I'm going to do that for somebody who's going to be out in the community, a community dweller, but I'm just not going to, just kind of use your judgment on that. But I do use these. These are my most common. Like I said before, they're not required, but they just provide more justification as to why your services are warranted for this patient's improvement and restoration. I put the link again at the bottom, the Shirley Ryan Ability Lab Rehabilitation Measure Database. That's a mouthful, but they have over 500 tests and assessments that you can choose from. All of these are on there, and you can search by the name of the assessment if the name of the assessment that you want to use, or you can search by just like what type of patient you have, the population that you're working with. You can search by what you're looking at as far as body part. If you're looking at dysphagia, which we wouldn't be, but that's an option, balance, vertigo, strength, anything like that, you can put that search in, and it's going to give you options of all these assessments that you can use, and they're all evidence-based. So they're all evidence-based assessments, and they provide you with the statistics of each one, how to perform it. If it's free and they have a copy, you can click on it there. It'll tell you what you need to perform. I mean, it gives you all the information and the statistics on those. So that's a really good tool to use. We've used that a lot. We have that saved on all of our laptops so that we can quickly find some of our assessment tools. But like I said, these again are some of the most common ones that I use. I did take this blurb from the CMS manual, chapter 15, the Medicare benefit policy. This is where it talks about objective evidence. And this is why you want to use standardized tests as much as possible. Like I said, I require 3 per patient. And like it says underlined here, and this is from page 36, they're not required, but they're used to enhance the justification for needed therapy. So they're great to have. Okay. Especially I've been noticing with these HMOAs, your Humanas, United Healthcare, things like that, your Medicare supplement policies that we're getting now in Swingbed. They're really going to need some objective measurements. You don't have those standardized tests, and it's hard to fight for an appeal, but you have these standardized tests. You're proving they're improving. You're proving that what you're doing is working, and that they still need your services. It is still medically necessary, and that they need your services to restore to their prior level of function. Then you have a lot more room to stand when you have these standardized tests provided. Another portion of the CMS manual actually provides you with 4 measurement instruments that they recommend but are not required. So of course, speech language is the first one. The patient inquiry by focus on therapeutic outcomes. I looked this one up because I wasn't familiar with it, and it's an online web-based assessment activity measure post-acute care, the AMPAC. I know someone brought up 6 clicks last time, and in my brain fog, I was completely lost with it. But 6 clicks is actually the short version of the AMPAC. I have been using this a little bit more. We don't have as many acute patients in our rural hospital at the moment, but when I do get an acute patient and they're really kind of up in the air as to whether they are able to safely discharge home versus if they need a skilled nursing facility or even swing bed, I will do the 6 clicks so that, again, if I'm trying to get them into the swing bed program and their insurance does not want to pay for it, I have this assessment to say this person scores this score. They are at much higher risk for a readmission to the hospital if you send them home. So it's just justification that they need extended help. They need the nursing care. They need the therapy more than just going home on an outpatient or home health basis. And then the optimal, that is something that the APTA put out. I did print it off. I have not ever used it, to be honest. It gives demographic information for the patients. It has a difficulty baseline and it has a confidence baseline. So how difficult it is to kneel, to balance, to hop, jump, run, push, pull, all those type things. And then how confident you are in doing those things. So that's an assessment as well that you could use. Like I say, it's right there in the CMS manual. So it's great to have that. All right, so that was kind of our backup. Now we're going to push forward to the thinking outside the box, therapy services, where we're not only somebody comes in, the one I always like to use is someone comes in with a shoulder fracture. Okay, so interdisciplinary team approach. So we have been drilling this for the past probably 2 years during our trainings. When someone comes into the swing bed, or outpatient or anywhere, it doesn't need to just be a one discipline approach. Say someone comes into swing bed and they have a shoulder fracture. Okay, so you're going to have to go in as PT. You're going to be like, well, nursing says they're walking around fine. They just have a fractured shoulder. You're not going to run in and you're not going to do a quick screen and say, oh yeah, they're fine. They just broke their shoulder. You know, they're okay. We're not going to pick them up. What you're going to do is you're going to evaluate and you're going to do a full-blown assessment because there may be some underlying issues that you're not aware of. How did they fracture their shoulder? You got to dig really, really deep. You can't just leave it to the OT to say, okay, now I'm looking at the range of motion, their ADLs, things like that. How they fracture, they fell. Now we've come to the bottom of it. They had a fall. So how do they have a fall? You go through an extensive assessment. You can check strength is fine. You can check balance. You can do different things with their balance, checking their vision. Their vision is fine. Then you get to their vestibular system and you start working on that and you realize vestibular system's off a little bit. Let me dig a little bit deeper with the vestibular system. And then you go into when you failed, do you remember how you failed? Did you black out? Did you get dizzy? Well, I got a little dizzy. Well, what were you doing? I mean, you really, really have to dig. And then come to find out, you may realize that this person fell because they got dizzy when they got up out of the bed or when they turned their head to turn around and change directions. You just have to really, really think deep on these evaluations and these assessments because now you've gotten to the root of the problem. So OT is treating for the shoulder and the ADLs, and PT is now working on the vestibular system, balance if needed, things like that, to work on the root of the problem. Throughout your treatment, you may realize that, hey, I don't know, there just don't seem to be answering my questions to the full capability. You can do a quick orientation assessment, a quick directions, like, how they follow directions, one-step directions. And if they have trouble with that, definitely get your ST involved. It could have been that they forgot to take their medicine that morning and that's why they were dizzy. I mean, you really just have to dig deep, but everybody needs to be involved, because now S can work on medication management and other cognitive deficits if they're having those. So that's what I want really everybody to think about when they're doing physical therapy, on a patient in the swing bed. Don't just go in and say, hey, I'm here to do, I'm here to do your therapy. Be thinking outside the box. Look at things that you see that they do that you really need to consult with your OT about, that you really need to consult with your ST about, maybe nursing. Maybe you go in and they're not feeling well, they're dizzy, and you do some orthostatic blood pressures and they're orthostatic. Well, now you got to take that to nursing. You don't just take that back to your documentation, because if you're like ours, yeah, you want to put it there. But if you're like our documentation system, it doesn't interface. So our nursing does not know what therapy did until we print the note off and put it in the chart, unless you communicate. So you want to make sure that you're communicating their blood pressure. So then you let nursing know, and then it may be an issue where their blood pressure medication was too much, or they're taking too much of it too many times a day, or whatever the situation may be. But then the doctor gets involved. Then pharmacy gets involved. So you really, really want to use the interdisciplinary team approach. I kind of jumped to the bottom on that one. All departments work together in Swingbed, because you're really working towards the same goal, and that is to get the patient back to their prior level of function, and sometimes even better than their prior level of function. You don't know what kind of quality of life this person had at home when they were dwindling away before they got to you, and they really needed some therapy, and maybe even some medication changes. They may needed some nutrition consultation. They may need to change their diet a little bit, and now you can get them back to even better. They were diabetics, eating a crappy diet. They were a cardiac patient, eating a crappy diet. Now all of you have worked together to improve this patient's outcomes, and they're going home at a lot less decreased risk for rehospitalizations, and they're a lot more independent than they even were before. And they've left with a lot of education, a good education. That's another thing with the caregiver involvement and education. Sometimes if you live in a rural community, like we do home assessments. And if you're fully staffed and you're able to do this, we do home assessments. We do home evaluations. And we usually try to do that within the first 2 weeks or so of their admission to Swingbed, if they're able. We do have some that come in maybe vent dependent that are not able to do so. So you just have to use your judgment when the person can come off the vent. It may be, a month down the road before you can take them home. But before they get fully ready to go, you're going to want to go with them to their home. And we assess everything. We assess them getting in and out of the car. We assess how they do everything on a daily basis in their home. And we make recommendations. We send them down right there. The family member is present, of course, because they transport them. And we provide education on things that we saw. We provide education on some modifications for the home that we think can definitely make that person more independent and make that person safer in their everyday activities. If they live, we have a 60-mile radius policy. That's what we use here. So some hospitals, you don't have, especially critical access hospitals, you might not have, a lot of room there. You've got people coming in from 70, 80, 90 miles away. And in that case, what we do, if it's not feasible, we don't have the staff, we're not able to get to the home, maybe the family is not able to come and take the patient to the home, we have other things that we do. One of the things I think I put on, I sent it the last go around, and we may have talked about it, touched on a little bit, was and I'm looking at it, that's why I'm looking down. I've got a check for safety, and it's a home fall prevention checklist for older adults, and it's put out by the CDC through their STEADY program, which is stopping elderly accidents, death, and injuries. And I did send this link last time, and we can put it on again if we have some of you that were not here last time. But it allows a family member to go through the home and check these things off. if there are loose or uneven steps, maybe they have steps inside their house. Is there, I would say if there's a grab rail on the steps, but you would think a 2-story house would have a grab rail. I've been in one that doesn't. I was very shocked. And the outside was open, just open to air. I mean, just could fall straight off. I don't know how they got through that. Anyway, light bulbs, are all the lights working? Are all the locks working? Do the windows open? Do the how wide are the door frames? Is there, how wide is the bathroom? Are we able to safely maneuver a wheelchair or a walker around in the bathroom? We have them measure the height of the bed. Say a patient has a higher bed, but they're not really, they don't know how high it is. And our beds, they go up and down, right? So we can kind of adjust it however we need to allow the patient to get up more independently, but they're not gonna be able to do that at home always. So we have the family measure the height of the bed. So they bring all this information back to us. We sit down with the patient, we sit down with the family member, and we give them education on how to modify that home to make it a safer place, to decrease the risk for environmental fall hazards. And then when we find out however high, 17, 20, 22 inches high, whatever their bed is, then we elevate the beds to those heights. And that's what we practice, getting in and out of bed at that height. Some kitchen chairs still do not have armrest. And I took a lady home one time and she thought that would not be a problem. She always sat at her kitchen table. She could not get out of that chair for anything. She could not get out of that chair. So that's another thing that they're looking for on the checklist. Our mom and dad's favorite chair got armrests? Did the kitchen table where they sit to have their breakfast, does they have armrests? They may not have needed them before, but they need them now. So those are some things that you can do to help reduce the risk for fall and rehospitalization once they're out in the community, if you can't physically get out to them to do that home assessment. So that's definitely something that you can do. You can also provide your patients and their family members with resources in your community. If there are gyms that have exercise programs, they can do that. There are some silver sneakers, I think, that most insurances will cover if it's on their plan. And that's a good resources that gyms have. Good socialization, getting them out of the house, getting them moving. But they also, if they're not one that wants to get out and about, you can refer to home health, of course, or like I think I mentioned before, the Otago program. It's actually 40 something, 50 something pages, 60 something pages, but it's a progression. And it is also an evidence-based program. I also sent this link. This is an evidence-based exercise program because evidence shows that you can't do just strength to reduce falls and you can't do just balance to reduce falls. You have to do them together. So this program will give patients and their family members a starting point for exercises, just beginning with head turns. Just something very easy if they're not able to even stand that well yet. And then when we progress to heel walking, no support. Of course, it progresses to support first, and then it goes to no support. But this is a great progression, and we just have our patients do some of the strengthening. There are some strengthening exercises in here and balance exercises. And we just have them check off this each time they come. They did these exercises at home. Okay, now we're going to progress to the next level. So that's kind of one resource that we give our families and for home exercise program, because it's proven to work instead of just, pulling some exercises together for risk for falls. Most of them are here that we would pull, but this, like I said, this is evidence-based and that's what you want. So, okay, so that's the resources. Hydration recommendations. We have been seeing a lot of patients who are coming in dehydrated, urinary tract infections, things like that. Even while they're in swing bed, you really want to be an advocate for your patient and, make sure that the staff is providing water and fluid. I mean, depending on what's consistency they're able to take in, whether it's thick or honey thick, nectar thick, whatever the situation may be, they're supposed to provide hydration. They're supposed to provide liquid for that patient to be able to keep them hydrated. So make sure you're being an advocate for your patient too. Like I said, we're PTs, but we also want to do other things that's going to help our patients. Okay. Anything we can do to help our patients, and whether it's hydration, whether it's, like I said, home exercises, nutrition. If there's something, you go in and it's a diabetic patient and they've got snacks stored away, and, educate them. That is in our scope of practice. Educate them that is going to make them feel cruddy. That is going to elevate their sugar. That is going to do this. That's going to do that. And it's going to make them not be able to perform well and not feel well and not make progress. So those are the kind of things, specific diagnosis condition handouts to families. That's another thing I have on my notes. I wanted to mention, like diabetes, I just mentioned that, but different things like foot care, diabetic foot care. That's not something that people go over a lot. And if you're the person treating them and you're seeing them a good bit of the time, you can provide that diabetic foot care. Give them a handout. Teach them how to care for their feet. Diagnosis such as dementia. Sometimes family members are they don't know how to handle their patient, their family member with the dementia, their caregivers, and they don't know how to handle it. Provide them with handouts on how to handle, their loved one who has dementia, and the different things that you have to do. Provide education to the staff. We know that with dementia patients, and they're in the swing bed too, and we know that they have a limited visual field. We know that they have hypersensitivity in certain areas. So they're not going to be prone to being excited about ADL care. They've got to take it slow. They need to get in front of them when they come in. Don't come in from the side and start just jabbering about what they're going to do and then just start pulling on this and pulling on that. You've got to really take it slow, but provide that education. That's a department interdisciplinary team approach. And I can go on and on and on about that, but I'm going to move on. Those are just some examples, but I could literally speak all day on the things that we could do thinking outside the box. We're not just the total knee. We're not just treating the knee. We're treating the patient. Okay. That's what we're treating. Another service that you can utilize if it's allowed in your state and then you are in a rural community, and therapists are hard to come by. So when you have one out, we're having to struggle to get PRN and this, that, and the other. And sometimes telehealth can be very, very beneficial, especially in a low staffing situation. They can be used for the supervisory visits. How we have to be supervised, every 5 days you have to have the progress note, the supervisory visit. UOCs, you have to have that supervisory visit. These can be used for the supervisory visits. Like I said, you'd have to check your state guidelines, but you can use the telehealth. That way you're still remaining in compliance with your supervisory visits, your progress note visits, updated plan of care visits, and your assistants are not treating outside their licensure. Decreasing lag time for initiation of treatment. This is where we have had some good results with telehealth. Is we had a patient. We don't have to use it a lot here. Like I said, we're very blessed to be fully staffed. But one of our other hospitals, our sister hospitals that we partner with, has had to utilize this because of COVID. One time they had one OT and she was out. So to get that patient in swing bed started and that initiation of treatment started in a timely manner, day 1 or day 2, depending on when they came in the building, telehealth evaluations are a great option. And it's giving rural patients more access to care. So when you have patients who have difficulty with transportation, you can utilize the telehealth services. The codes were originally set, telehealth codes for therapy were originally set through COVID, but they're still allowing us to use them because they're really gathering data to see how helpful and how beneficial it is to their beneficiaries. So if you need to use it, use it. It's a great tool. Maintenance therapy. This is something that is kind of sticky. It's a sticky situation, but you can treat a patient for skilled services under a maintenance program. As you see here, this again is from the Medicare CMS guidelines. It does not, let me see, I've got something in the way here. Okay. Coverage in the nursing home, aka Swingbed, because I know, like we said before, critical access hospitals do not follow MDS guidelines. However, it will come to that at some point. And you also do obtain, or you do get denials at times. So, and we do want to follow those MDS guidelines as much as possible, because like we said, it's coming. That's the tool Medicare uses, and you really want to follow them now so that you can kind of avoid some denials in the future. But maintenance program does not turn on the presence or absence of an individual's potential for improvement from the care, but rather on the beneficiary's need for skilled care. So the goal requirement is if you're trying to maintain the patient's current condition, the documentation would serve to demonstrate the program's effectiveness in achieving this goal. So what are you doing? This patient has Parkinson's. So this patient has a debilitating disease that is progressive. And you know, in your heart of hearts, they're coming 3 times a week or whatever. This is outpatient. Let me go back to Swingbed. They come in, and you know, in your heart of hearts, you've seen them for a month and they're in Swingbed for whatever reason it may be. They're still there. They've got underlying medical issues. And you feel like, I know that I can, if we do not treat this patient, they've kind of maxed out on the progress per se for therapeutic intervention. You haven't seen much change, but you know that if you do not see this patient, they will decline, their function will decline. Then we are going to try to maintain their current condition, and that is what we're going to document. We're documenting a maintenance program to prevent a decline in their condition, or if it is intended to slow the further deterioration of the patient's condition. Currently, we have someone, an outpatient, that's a Parkinson's patient, and we have him on maintenance. So the program has to be complex enough that it can safely and effectively be performed only by or under the supervision of a qualified therapist. At our facilities, we only allow our PTs to treat these patients, just so there's no question. You got an assistant or something that forgets to document that they were under supervision of a therapist. We don't even want that. We're going to go ahead and we're just going to have a PT treat these patients, okay? Because it's a very complex program and you're having to reassess over and over and over and over. It also demonstrates that the specialized judgment, knowledge, and skills of a qualified therapist are necessary for the performance of a safe and effective maintenance program. So it needs your judgment, your knowledge, and your skills to be able to perform this program. No Joe Smo off the road can do this, okay? And the program is to maintain the patient's current condition or to prevent or slow further deterioration is covered so long as the beneficiary requires skilled care for the safe and effective performance of the program. So you can continue on as long as you meet these guidelines and your documentation proves that without your services, you will, this person will decline, okay? Okay, so that was the blunt of it. That was most of it. I thank you for coming back and joining me for the end, and this was a little bit quicker. I will answer some questions here now, and I have 2 that I'm going to answer from a previous email, but following this presentation. If you do have any questions, please feel free to forward them over to Carrie, and she'll get with me and we'll get them answered as they come about. Okay. Okay. One of the questions was, can you charge for group activities in Swingbed? For example, car playing. Okay. So the answer is yes, you can charge for group activities. However, it has to be 2 to 6 patients. Used to be 2 to 4, now it's 2 to 6. And they are being seen at the same time, and they're performing same or similar activities. Okay, so you can do that. However, under MDS guidelines, you can only perform this for 25% of the time of the entire stay. Okay, so and you don't want to go over that. I know, like I said, you don't follow MDS, but they will get a warning for those of you, for those hospitals, swing bed programs that do follow MDS and skilled nursing facilities. They get a warning if they go over 25% of the time is given by or given through group therapy. So, so those are the requirements. So it's only 25% of the total episode of care is what you can do for group. Okay. The documentation requirements for group therapy have to explain the reasons for choosing group. It can't just be that, you know, you didn't have enough staff that day. It cannot be because of the convenience of the therapist. You have to document that the reason for choosing the group, and you have to explain how that type and amount of group therapy will benefit the patient, including specific benefits to the particular patient, such as how it will meet the patient's needs and assist the patient in reaching their goal. So you would have to document why a group activity was better than an individual activity at that time, and why this card playing, how this is going to help them in a group setting is going to help them meet their goals. Okay, so I'm reading that directly out of Medicare guidelines. So that's, if you need more information on that, you can definitely go there and then it'll give you more information. But one thing it definitely does state is that you should never provide at the convenience of the clinician or the facility. Okay, and it says be on the lookout for situations that may occur where group sessions are provided for the wrong reasons. Staff shortages, staff convenience, boosting productivity. Those are only provided to one payer type, HMOs. You know, we don't get paid as much sometimes for the HMO patients, and we get paid on a different schedule, and we're only providing group therapy to HMOs, but not traditional Medicare. Can't do that. And Medicare does state that they prefer independent or individual therapy, but they will allow it, like I said, 25%. So that's the shorter answer for that. Like I said, Medicare guidelines, you can find that in the CMS manual, and they'll break it down a little bit more. But yes, it is allowed. The second question was, during family meetings, can both PT and OT charge for that time with the patient and family, or only one discipline? Okay, so if you both charge, it would have to be a co-treat. I don't see a need to co-treat during that time. Patient does have to be present for you to charge at all, but I do see that you said with family, with the patient. A time is coming there in the next year or so where we will have a family or a patient caregiver education code. I may have said this last time. We will have an education code. The patient will not have to be present, and you can actually charge for your skilled services of giving education to a family member. I love that. I think that's wonderful. It's coming, but it's not here yet. So, but if the patient is there, what I would personally do, because I think that's a little bit too sketchy for a co-treat, I would divide the time, honestly, because you're not both talking at the same time. I would divide the time between the two. So if you're in there for a 30-minute care plan meeting, I would give 15 to PT and I would give 15 to OT. That's my personal opinion. All right, and that's the two questions I have. Becky, if you have anything else.
No other questions have come to me, but definitely chat in any questions that you have and take advantage of Amber being online. We have about 3 minutes left, or simply unmute your line and just ask her a question directly, or if you have a question for Carrie. So we will pause and give everyone an opportunity to think about it. I hope that today has been helpful and answered some questions for you or gave you some different ideas.
If you do the home assessments, how do you charge for that? Say it takes you 20 minutes to drive to the home, takes you 30 minutes to do an assessment, 20 minutes back. Are you only charging for that 30 minutes that you're at the home assessing? And what code would you use for that?
Okay, so and my drive time is 40 minutes at this point. So I'm charging my facility 40 minutes of drive time. And then I am charging, if you're at home, it depends on what you're doing. Are you focusing on the time that you're focusing on gate? If whether you're in the home and you're working on gate, over level surfaces, flooring changes, or if you're working up and down steps or outside in the yard, gate. If you're working on transfers, in and out of the bed, activities that they do throughout the day, reaching activities, then I'm gonna go there at that point.
Any other questions? Okay. Well, thank you again so much, Amber. This has been wonderful. Carrie, do you have any comments here at the end? And we may have lost Carrie. Okay. Well, thank you all. Please stay safe. Thinking about those that have been hit by the tornado, and let IHA know. I know leadership is reaching out if you need any assistance, and everyone just stay safe. Let me know if there are other questions you think of after the program today, and we will work to get those answered. So
Yes.
thanks.
And thank you for having me. And you guys are in my prayers. I know this weather has been terrible. So I hope you all stay safe.
All right. Thanks so much.
Thank y'all.
Bye-bye.
Bye.